Hi, good evening, everyone. So nice to meet you all. My name is Dr. Xiong. I'm a first-year resident in family medicine at the University of Toronto currently. And this first hour is going to be in English since almost all of you are students. So I'm going to use a PowerPoint and today's module 1 of the medical school preparatory class. And afterwards, the second hour is going to be in Mandarin. So let's start right away since it's already 7 o'clock. Let me share the screen for the PowerPoint. By the way, if you have any questions, don't hesitate to just write it inside the chat, and I'm going to answer them when I have any free time at the end of the PowerPoint. Okay, so here is the PowerPoint. If you cannot see it, then just message me on the chat. I'm going to adjust the PowerPoint afterwards. So today is module 1, and I really want to tell you what a doctor is, because I know a lot of you are really interested in medicine. You want to apply to medicine, and usually it takes more than like 1 year to just prepare all the documents you need, no matter if it's the recommendation letters you want to get, the CV, or the CASPER exam, the MCAT exam. So before dedicating all that time on the different components of the admission test, then you really want to know if medicine is a good fit for you. Because medicine takes almost 10 to 15 years of study before you become a fully autonomous doctor. Okay, so today's class, I'm going to tell you what a doctor really is in the Canadian environment. And also in the interviews, as well as, well, we correct your CV or your personal letter, we also want to see if you have real interest in medicine. And every year it's medical students and residents themselves who actually mark the CVs, mark the interviews of the new applicants. So we would design these questions every year, which just want to probe your interest into medicine. Sorry, so can all of the people just put on mute their microphone? Thank you so much. Yeah, so basically we have these kind of questions. We want to ask you, why do you want to become a doctor? Why don't you want to become a nurse or a pharmacist? You say you want to help people. Nurses can also help people. Pharmacists also have knowledge of science. And nurse practitioners can also make simple diagnosis. So why medicine especially? So this is the first question that applicants need to think about, because you can never avoid it during the medical school application. So first, I'd like to describe what are the roles of a doctor. So there is CanMed roles. CanMed is for the Canadian Medicine Association, and there are 7 key roles that a medical student and a resident, which is the second step after medical school, should try to learn and master before they become a full-fledged physician. So here are the 7 roles. We have professionalism, communication, collaboration, leadership, health advocacy, scholar, and at the center of everything, it's medical expert. So during our application, no matter if it's the interviews, the CASPER, or your personal letter, we are going to mark you on these 7 competencies. Sorry, my mistake. Only 6 competencies, because medical expert, we're not really expecting you to know anything about medical knowledge, since that's our duty to train you afterwards. You may know things about the healthcare system, about COVID, about the news and global health, but we don't need you to know anything about the human body. What's an acute appendicitis? What's the difference between diverticulitis and diverticulosis? These things, it's our job to train you afterwards. So medical expert is not the competency we expect you to master during your application, but everything surrounding it is very important. So let me tell you by a concrete example why these competencies are very important. So this month, I'm at downtown Toronto's Mount Sinai Hospital for emergency. And right after I finish talking, I'll go back over there for an overnight shift. So emergency medicine is a shift-based environment. So for example, in a month, I have to go to Mount Sinai about 10 to 15 times. And every shift is about 8 hours. It can be any time in the day. So how I can use these different roles to actually master the art and the science of medicine in the emergency context. For example, the first step when I go into the emergency room, I have to introduce myself to a new preceptor, to a new teacher, because that's how it works in emergency. Every day you are with a new teacher. It changes every day. You don't know the teacher, so you really have to have good communication skills to know what the preferences of the new teacher is every day to adapt yourself. You need to have good collaboration skills because from the moment you choose your first patient, the nurses at triage or the paramedics may already have a lot of information about this patient. So collaboration is key. You have to ask them what happened to the patient. Why is he unconscious? Has he taken any drugs? That's what happened yesterday during my shift. I had to ask all the questions, not to the patient himself, but to other people around. So that's collaboration. What is leadership? So leadership is the fact that you must actually manage your own practice. So medicine is your own practice management. You are not working for the hospital. You are not hired by the hospital. You have to build your own salary to the government. You have to decide, okay, so every Monday I see 5 patients. Every Tuesday I see 20 patients, where I should go. So it's kind of like a small business. So you have to get these leadership skills. It's the same thing for me in the emergency department. When I go there, I choose my own patients to see. And at the end of my shift, I don't want to see these patients with too much complex comorbidities, problems, because I know I only have 1 hour left. If I see them, I may be stuck in the emergency for another 6 hours. So that's the leadership management part of medicine. Health advocacy is also called health promotion. You want to promote good stuff to the patient. Advil is very dangerous to use in patients over age 65 because of gastric ulcers, bleeding, because of kidney dysfunction. So what is health promotion? So besides just treating the acute pain of the patient, you have to tell him or her, look, Advil is not good for you, stop it. And you have to help each patient when you have the occasion to do so. So that's health advocacy. Scholarship is simply the fact of reading around your cases and reading around the new findings in medicine. What you learn in med school, maybe in 5 to 10 years, is all going to be obsolete. Maybe it's going to change. There's going to be new knowledge saying that Advil is not good anymore. It's too dangerous. So every day we have to read around new scientific articles in the Journal of Medicine and Nature and see what are the new treatments available for our patients and use them directly according to evidence. So that's scholarship, interpreting research articles and doing research yourself. And the last competency is professionalism. So what's that? So I'm in the emergency room. I have to see a 20 years old female patient who just got raped, who had a sexual aggression. That was my case yesterday. First, I can't reveal what her name is. Confidentiality is key. You breach that, it's not only a question of professionalism, it's a question of even risk of criminal activity to just give out the information. And you need a nurse to help you for examining the patient because you are a male patient and you are a male physician and the patient is female. So there's risk. That's all about professionalism and ethics of medicine. So these are all the competencies that can help me in my emergency shift and in medicine in general. So now let's talk a little bit about the medical specialties that there are. A lot of the applicants every year, they come to write a personal letter. They say, I want to become a doctor because I want to prescribe eyeglasses to patients. But eyeglasses, you don't have to be a doctor to prescribe that. You should be an optometrist. That's what optometrists do, and they are not doctors. What doctors of the eyes do, they perform surgeries of the eyes. We call them ophthalmologists, and they are surgeons. So knowing what is a doctor and what is not a doctor is going to help you in your application so that you don't make basic mistakes. I want to become a psychologist. That's why I want to be into medicine. But psychology is not the same as a doctor of mental health, a psychiatrist. These are different things. So in medicine, there are overall 6 major groups of specialties. And across your med school, you are going to go into rotations in all 6 of these groups. So how does med school work? There's around 3 to 5 years of med school. In the first half of med school, you're going to learn all the theory about the human body. So 1 month about the kidneys, 1 month about the heart, and all the different diagnoses you can have, etc. And the second half of med school, you're going to go into rotations. You're going to act as if you were already a doctor, but in training. And you're going to follow different teachers every time. And these are the different rotations you're going to follow. These 6 big groups of specialties. First is primary care. I am a resident in primary care and family medicine. Primary care can be family doctors. They can also be emergency doctors. In short, when you have a problem, you cannot see a specialist in Canada directly unless you already have a specialist. If you don't have a specialist, then you should go to your family doctor, to the emergency room, or to a walk-in clinic to see a random family doctor. So that's primary care. And second, there's internal medicine. Internal medicine is, in short, hospital medicine. So let's say I see my family doctor and he cannot treat me in the clinic. I'm going to transfer the patient to the hospital, and internal medicine is going to take care of the patient afterwards. Pediatrics is everyone below age 18. So you take care of children. Surgery is doing operations. Everything that you do by hands is surgery. Obstetrics, gynecology. So these are the doctors who take care of pregnancies. Is this surgery? Definitely yes. These are surgical specialties because imagine you have a C-section, a cesarean section to perform. These obstetricians are going to do it. Family doctors can also perform baby deliveries, but they are not surgeons. So they can only do normal vaginal deliveries. If there's a C-section, you call the obstetrician. How about psychiatry? Psychiatry is about mental health. And as I said, it's different from psychology, which is not part of medicine. So psychiatry, you talk with patients all day and you don't have to operate. You don't even need a stethoscope. And the last part is non-clinical specialties. For example, radiology, pathology, and public health. So these specialties of medicine, you don't even need to see a patient all your life. You're working with images, the microscope, and government reports. So now let me describe each of these specialties to you because there may be one question during the interview they ask you. So you're interested in medicine. Is there any preferences over specialties? And a student who never read about medicine, who only knows, I know it's prestigious, I know it requires a high GPA, I had no idea what medicine is, may say, I don't know, I want to become a doctor of the heart. What is a doctor of the heart? Is it a cardiac surgeon or is it a cardiologist? Because cardiologist is internal medicine, you don't operate on the heart. Cardiothoracic surgeon operates on the heart. These are 2 different paths. So before going through the specialties, let me just tell you what are the different healthcare environments you may work in later on in your life as a doctor. So first, as a primary care doctor, you may work in a family doctor's clinic, an office. So these are called outpatient settings. Outpatient settings only means that the patient doesn't sleep in the hospital overnight. You come to the hospital in the clinic, or you just go to a clinic and then you leave the same day. That's also called an ambulatory clinic because the patient is able to walk. He's not bedridden and doesn't need any care inside the hospital for more than 1 night. Next, we have the emergency or urgent care setting. You have the emergency room inside the hospitals and you have walk-in clinics. So in these cases, it's more urgent. It's like a family doctor's clinic, but you say, oh, I can't just wait 2 weeks to see my family doctor. I have to go there right now. So you go to urgent care clinic. Next, you have the inpatient or the ward. So inpatient and ward, these are simply the hospital. If a patient needs to sleep in the hospital for more than 1 day, that's called inpatient. We admit the patient. Next, there's the operating room. That's pretty easy to understand. Next, that's a very hot topic since COVID appeared. It's virtual care. So virtual care is just like me and you right now. I'm teaching you stuff over Zoom. I can examine the patient over Zoom too. Virtual care works more with specialties that don't need stethoscope to listen to something because obviously you can't listen to the screen. But for example, dermatology, skin doctors, they can just look at the skin. No matter if they're there physically or not, you can diagnose the problem most of the time. Mental health, psychiatry, you don't need to see the patient physically to diagnose his conditions. So virtual care is only for certain specialties. There's also the environment called diagnostic, as I said, the non-clinical specialties. So radiologists, someone may say, I want to become a radiologist if I get into medicine because I want to put the patient into the x-ray room. I want to take photos of them. But that's not the radiologist who does it. That's the radiology technicians who do it. Radiologists stay in the dark room all their life and they read images of these patients. They don't see the patient. It's the same for pathologists. Pathologists, they stay in the lab. Their work is they look under the microscope to see if the cells of a patient are cancer cells or not. That's why we need them after surgery. So this is diagnostics. And the last setting where doctors can work is government facilities. These are public health doctors, and they have become very popular since COVID appeared. These doctors have followed a specialty of 5 years during residency called public health. So they do a master's of epidemiology during their 5 years, and they stay in the government. And they work reading reports and making decisions for the government. So now let's go through all the different specialties one by one so that you can know which preferences you have and if medicine is really for you. So I'm in family medicine, so I'll first start to introduce what family medicine is. Basically, family doctors, it's mostly office work. After they graduate, they may never get into a hospital to work. It's mostly in the office. Of course, family doctors only need 2 years of residency instead of 4 to 6 years for other specialties. But family doctors can also have a 3rd year training in hospital work and still work in the hospital. For example, emergency is 2 years family doctor, and plus you can do 1 extra year of emergency and you become an emergency doctor. So family medicine is very flexible. You are studying every part of the human body. That's also mostly why I chose family medicine. You don't have to forget everything except one organ, like internal medicine or surgery. And you can help patients directly since it's the first line. Patients will see you. You have a longitudinal care with the patient. So you see a patient, he's going to be your patient for all life. It's not like radiology or emergency medicine where you see the patient once, the image or the patient himself, and then goodbye. You're never going to see the patient again. Family doctors need to have good communication skills because it's all about the relationship with patients. You're going to follow them for 40, 50 years of your life. So you need to have a good relationship with them. And family medicine is also very entrepreneur oriented. And that's something else I like. So family medicine, you work in clinics, you can run your own clinic, you can run a lot of clinics. So all doctors are self-employed. They can work for themselves, by themselves, at their own home with a license. But the problem is, if you are a surgeon, you can't really start an operating room inside your house, right? That's going to take billions of dollars. But the family doctors don't need such constraints on the material. They don't need an MRI scanner. They don't need a CT scanner. They don't need an operating room. They can actually run a clinic inside their own house, or they can start new clinics. And that's the entrepreneur part of family medicine. And family medicine can also get into partnership with clinics already that exist. These clinics may be run by family doctors themselves who are already settled, or they may be run by businessmen themselves. So there's a lot of clinics in the Greater Toronto area that are run by businessmen, and they say, look, I'm the owner of this building. You can work here in this building, and let's split all the earnings, for example, 25% to the owner and 75% to the family doctor. So that's a partnership we make. That's called the overhead fees we give to the owner of the building, and they take care of everything that is non-medically relevant. For example, Wi-Fi, water, hiring receptionists, secretaries. They take care of everything, and you just focus on your practice. And there's something else about family medicine, is that there's rarely any hospital calls. So you don't have to stay in the hospital 2 weekends on four. That's more surgery and other specialties. So it's more human-centered than every other specialties. That's family medicine. Now, emergency medicine. Emergency medicine is something I'm doing currently, and right after this class, I'll go to Mount Sinai for a shift. So it's a shift-based work, and the shifts can be very, very irregular. So that's why emergency is more for young people. Yesterday, I had a shift from 9 o'clock p.m. to 4 o'clock a.m. in the morning, and I slept 6 hours. And today, my shift starts at 11 o'clock p.m. to 8 o'clock a.m. next morning. So I'm in jet lag currently. And that's emergency medicine. If you are an applicant who loves this kind of irregular schedule because you're young, obviously, then emergency is for you, because there's a lot of adrenaline. Every day you're going to see different patients. You don't have to build a continuity with the patients themselves. You see a patient and that patient is gone. You're never going to follow up with this patient again. The patient is going to follow up with the family doctor afterwards. So there's no patient continuity. It's very, very broad. It's just like family medicine. You have to learn everything, and it's all acute care. So family medicine can deal with chronic diabetes. Emergency doesn't have to deal with it. It's all like life-threatening situations you have to save patients for. And emergency medicine, basically, they have to advocate for their patient. That's why health advocacy is very important. So yesterday, I had a lot of patients who were sick, who had to be admitted to Mount Sinai Hospital. So how does it work? The patient first comes to the emergency, and afterwards, I have to call the specialist. I have to call general surgery or internal medicine and tell them I have this patient. The patient needs admission. And the specialist may be more arrogant. They may just say, no, I have no bed for them. But you really have to fight for your patients to get them a bed. You can't just let the patients leave. So that's how communication skills and collaboration skills are also very important. So next, we're talking about internal medicine. Internal medicine is about everything non-surgical, but that's a specialty. So emergency medicine that we've previously talked can be 2 years family medicine plus 1 year of emergency during residency, or it can be a 5 years specialty in emergency straight. If it's 5 years emergency straight, then the drawback is all your life you're going to do emergency. You can't do family medicine because you have no training in family medicine. So you become a specialist of emergency medicine, but you're going to do more research, and you can stay in bigger academic hospitals in downtowns of cities. So next, let's talk about internal medicine. Let's come back to that. Internal medicine is also 5 years of residency, just like specialists in emergency medicine. So internal medicine, you have cardiologists, nephrologists for the kidneys, you have respirologists for the lungs, you have oncologists for cancers. You have one specialty for almost all the systems of the body, and all your life, you're going to dedicate yourself to that system of the body. Nephrologists, they're going to learn everything about the kidneys, learn a little bit about all the other organs, and they know absolutely nothing about all the skin conditions because it's not relevant to their practice. So internal medicine deals with inpatients who have to get admitted into the hospital. So patients are sicker with more complex multiple health issues. They may have liver failure, lung failure, heart failure, and have other more comorbidities, and have 20 medications, 30 medications to take. So internal medicine requires a lot of multidisciplinary collaboration. For example, you are a nephrologist, a kidney specialist. You can't just deal with the kidneys, because if you give a medication for the patient's kidneys, it may affect the heart, it may affect the lungs, it may affect the liver. Everything is related together by blood vessels. So you have to meet with all the other specialists in internal medicine and find a good approach to deal with all these problems together. Internal medicine can be general internal medicine, so you still deal with all the different patients, no matter the organs. That takes 4 years of residency. Or you can subspecialize into the kidneys, the heart, cancers, the joints, which is going to be 5 years of residency instead of 4. And they take care of the patient not as primary care physicians. They don't take care of patients in the emergency room. They receive a call from the emergency doctors if a patient needs to get admitted. So every day in internal medicine, the internists need to come to the ward, for example, the 5th floor, the 6th floor of the hospital with 20 beds on each floor, and they have to round the patients. That's what we call rounding. May start pretty early for surgery at 6 o'clock in the morning. Internal medicine maybe after 8 o'clock in the morning. So you go see every patient every day. And you may also have consultations from other specialties. So for example, you are a nephrologist, again, a kidney specialist. All the patients in the wards may be under your care in certain hospitals, for example, with all the kidney failures, or they may be under the care of general internal medicine in other hospitals. So if general internal medicine takes care of the patients of the ward, you are just a consultant. You don't have to do the roundings every day. These are not even your patients. So every day, what you're going to do is wait for a phone call from general internal medicine or emergency saying that, look, there's a very difficult kidney condition. I have no clue how to deal with it. And then the nephrologists become the consultants. So next specialty is pediatrics. So pediatrics is everything of patients younger than 18 years old. So you're just like a family doctor, but with way more expertise on children, and all your life you're dealing with children. And you can also get subspecialized just like internal medicine. So for general pediatricians, it takes 4 years of time. If you are a subspecialized pediatrician, for example, a pediatrics nephrologist with kidneys, it may take 5 years. So you have 5 years of residency instead of 4. So residency, as I said, is the second part after med school. So first you do your undergraduate, then you go to med school, then you do your residency, and then you become an autonomous full-time physician. But during residency time, you are already paid. So you are already working. That's different from medical school. So let's get back to pediatrics. Pediatrics don't deal with surgery. They are just like internal doctors. If you have to deal with pediatric surgery, that goes to surgeons who are subspecialized in children. Pediatrics also deal with admission from emergency departments. So they're not primary care doctors either. It's not because I'm a pediatrician that all the children come to me at my clinic. They have to go through the family doctor or the emergency department and after get a referral to the pediatricians who are specialists. They also do roundings on the ward. For general pediatricians, they may be sick kids that they have to round every day. And they also have outpatient clinics. So specialists, in opposite to family doctors, usually work in the hospitals, but they can still have their own outpatient clinic. So if they want to be more entrepreneur, they can also do it. The problem is they may have less time to do it during residency and afterwards, because a family doctor may only work 30 to 50 hours per week, whether a specialist may have to work 60 to 100 hours a week just in the hospital. So they have fewer time to think about entrepreneur and how to open clinics. That's because the partnership with the hospital is different with the partnership with clinics. A family doctor enters a partnership with the clinic and you pay overhead to the building's owner. The hospital usually doesn't need you to pay 20% of your earnings to the hospital. What you're going to do instead is work an extra amount of time for the hospital. For example, I'm a pediatrician. I say, look, I want to have a position inside this hospital. And the hospital may say, okay, but you have to be on call 1 week on 24 hours call. And you say, oh, sure, yeah, why not? So that's the deal. And being on call 24 hours means that even if you're at home, every time the pager or the cell phone rings, you have to go back to the hospital. So that's the difference between the partnership with the hospital and the partnership with the family doctor's clinic. So now let's go to surgery. So surgery is the rotation I was on last month. And I can say that it requires a lot of passion to be a surgeon because it is mentally very demanding. My teacher, a general surgeon, was actually working for 36 hours straight when I met him on the last day of my rotation. So he never slept for 1 day straight, and he worked 2 days all the way. Surgery, they may have around 80 hours average per week of work. So you really need to be passionate about that. Otherwise, you won't make it till the end. Surgery is usually 5 years of residency. And you are on call 1 day on 3 for all the residency. So 1 day on 3, you're on call for 16 hours. And there may be 24 hours call. That's what obstetricians do. So they come to the hospital at 8 o'clock in the morning. They leave the hospital at 8 o'clock in the morning the next day. And if you are in the big hospital, like Sunnybrook Hospital in Toronto, don't even think about sleeping more than 1 hour during that 24 hours call. It's going to be very, very busy. So that's what surgery is. And when you have to actually perform surgeries, you have to stand there in maybe 2 hours and maybe 6 hours, who knows? So physically, you have to be very fit. Surgeons, there are a lot of types: cardiothoracic surgeons for the chest, for the lungs, for the heart. There's also general surgeons for everything, the bowels, the abdomen. There's the neurosurgeon. There's the orthopedic surgeons for the bones. So you're also focused on only one part of the human body all the rest of your life. You also are not a primary care doctor. So you need to get a call from emergency or from the family doctor to actually admit a patient and perform surgery on them. You can also have outpatient clinics if you still have time after 80 hours of work per week. And you can also have roundings on the ward. So a lot of patients, you perform surgery, they need to stay in the hospital for a few days for recovery. Every day in the morning at 6 o'clock, you have to go there to round patients until they leave. Okay, so next is a more interesting specialty. It's called psychiatry. So psychiatry is a different group because you don't have to perform physical exams on your patient. Psychiatry, for people who don't want to use the stethoscope, who love human interaction and not the physical aspect of physical exams, you can go into that. So it's very important that you have a good relationship with your patients. And these are very critical patients. Yesterday, I had patients who had sexual aggressions, patients who wanted to kill themselves. And there's a lot of legal aspect of medicine. I would say that psychiatry is very, very related to the legal aspect of medicine. For example, if a patient causes danger to him or herself or to society, I want to kill myself or I want to harm someone on the street, you have to force them to stay at the hospital. In Ontario, we have to form them. You have to write a form that forces them to stay in the hospital. So there's the legal aspect of medicine. Imagine the patient says, no, you can't do that on me, but you know you have to do it. They may actually pursue you at court afterwards. So you have to have this preparation every year to have at least one lawsuit. Besides that, psychiatry is also a specialty which requires 5 years. So same, you get calls from emergency or from family doctors. You're not first line to see patients. You have to round at the ward, see patients who are admitted, and you may have consultations from other specialties. For example, a patient comes for a bone surgery and suddenly the patient has depression, wants to kill herself. They may call psychiatry in the hospital and say, can you have a consultation on this patient? And that's how psychiatry is. You can also have outpatient clinics. Psychiatry is not really dependent on the hospital. You don't need an operating room. You don't need an MRI machine. You can actually open your own clinic inside your own home. Okay, and the last group of specialties in medicine is called non-clinical specialties. Radiology, pathology, public health, even genetics, you stay in labs. So these specialties, they really don't need to see patients. But I'm not recommending you guys to say, I don't want to see patients. That's why I want to go into medicine. I just want to go into radiology. Because medicine in general is about patient interactions. So these are non-clinical specialties. People who get into these specialties usually say, I still want to help my patient in other ways. They don't say, I don't like patient. That's why I want to go into radiology, because why the hell are you in medicine otherwise? Yeah. So radiology, you see images of patients all day. You also have call because it's also a specialty which requires 5 years. So you may stay in the hospital for 12 hours straight looking at CT images of the brain. It's very demanding. And because if you miss a stroke on the patient, there may be big trouble. So the hospital is really dependent on radiologists. When I'm working in the emergency, every day I refer at least 10 patients to the radiologist team. I say, there's a stroke, I think, please roll that out. There's a pulmonary embolism, I think, please roll that out. So basically all the job, they do it. If they miss something, there's going to be devastating consequences on the patients. So there's a lot of pressure put on this specialty. Same for pathology. Pathology, the surgeon biopsies, so takes a sample of the colon of the big, large intestines and says to the pathologist, is this cancer or not? The pathologist has to read it with the microscope. So there's almost no physical interactions with patients. You may have call and there's no continuity of care. You deal with the image or with the cells and that's it. You go to the next patient. So in short, these are all the specialties you can meet inside medicine. And when I'm talking about family medicine, you can actually do all these, but you're not the specialist of all these. So you have to know where your limits are. As a family doctor, I can see a patient with suicidal ideations. I can see the patient who needs surgery. I can see a patient who requires a CT of his chest, and I can even have a look at the CT of the chest. But you really need to know where your limits are because you're not dedicating all your training on these aspects of medicine. Okay, so you guys all want to apply to medical school. I'm just gonna tell you how physicians, doctors actually they teach inside medical school. So in the first part of medical school, as I said, it's mostly large classrooms of 100, 200 people, and then the doctors just come to give a theory class about the kidneys, the heart, etc. So this is very classic. You're going to have that during your undergraduate level. There's nothing new about it. But then it becomes more spicy afterwards because there are some medical schools that do a flipped over approach to teaching students. So they require the student to read about cases and then come to the classroom and they test them on the knowledge they read. So that requires leadership capacities or management capacities from the student themselves. They can't procrastinate and just think, oh, the teacher is going to give me all the information I need, because they're not going to do it. You have to read the cases yourself. And the only purpose why you come to class the next day is to get tested. So usually in medical school, if I'm a teacher, I won't tell you read this manual from page 10 to page 25, read this manual from page 25 to 30. I'm going to tell you, look, you're autonomous, you're a med student, go read about appendicitis and the management of it, the surgical management and the conservative management, and let's talk about it. So you have to find your own sources of information, and some people are more efficient. They may find the source of the information they need within 1 hour, learn everything. Someone else may be more like perfectionist, read 20 pages to get the same information. So students have to manage their learnings by themselves most of the time. On the second part of medical school, you are on rotations in different specialties at the hospital or in clinics. So how are doctors teaching you at this point? Every day you're going to follow a different doctor, and you may see the patient by yourself. So for example, I have 2 medical students with me. I'll tell them, look, the patient in room 12, I think he has a very interesting case of lung disease. Go examine him and tell me what you think. The student needs to go see the patient afterwards and come back. The doctor can also see the patient with the students as a role model, or the doctor, if he or she may be very busy, can ask the student to just read about a topic and come back the next day to discuss. So reading about the topic is something medical students tend to learn in the first part of medical school anyways. There may also be procedural assistance. That's more in surgical specialties. So for example, in the operating room, I was helping the staff surgeon operating on the patient. And you may have to deal with sutures as a student by yourself while the staff surgeon evaluates you, looks at how you do it. And there may also be workshops and simulations. So every week at Mount Sinai, I have to go for a simulation, a code simulation, so a cardiac arrest simulation with actors. I have to do an ultrasound simulations on actors too. So we do these kind of stuff too. And there's one thing you guys should know. Physicians, your teachers, are always slower with you. So at first I was complaining, like I was like, okay, you see that doctor with which we are with is actually using us to see patients faster. That's not true. All the physicians are way faster without the student than with the student. They can see a patient in 2 minutes, 5 minutes without a student. With a student, they have to learn about the case by the student themselves, which takes 10 minutes, teach the students, takes 5 other minutes, and see the patient again takes another 5 minutes. So that actually doubles, triples the time needed. Okay, so starting from now in the slides, I'm going to teach you some stuff that you're not going to see on the official websites of medical schools. It's called the hidden agenda of medical schools, or also what we call the hidden curriculum. So it's always good to go into medical school to say, I want to study, I want to get the best grades, I want to get into the best residency programs, I want to become a surgeon, go to Toronto. But the thing is, grades after you get into medical school are not very, very important anymore. Right now, almost all medical schools use this system called the pass or fail system. So basically, you have exams on the first part of medical school, theoretical exams. You have more than 60%, you pass it, you have a P on your mark. You have less than 60%, you have F, you fail, you have to retake it. So someone who has 90% or someone who has 65% is the same at the end. No matter for residency application or for anything else, it's the same on your general grades. What's more important in medical school is first, you have to impress the staff physicians, your teachers. Why I'm saying impress? Because the second half of medical school, every time you are on the rotation with your teachers, you need to receive evaluations from the teachers. They don't give you a score telling you, look, I'm going to give you a physical exam, your score is 90% or 60. They're going to write comments on you. I may say this student knowledge is above average, is below average, is on average, and they compare you to other students they also see. They may say this student has a good knowledge, has great knowledge, has excellent knowledge, has knowledge at the level of an attending physician, which is like the best compliment student can have. So basically they have to write comments and it becomes very, very subjective. And unfortunately, the comments is what residency programs look for when they decide whether you come to our residency program. You want to become a surgeon, you have to get good comments from all the different teachers because surgery is very competitive. So impressing the staff physician is very important. That's the hidden curriculum. Some staff physician, I have to admit, they just don't know how to grade a student and they just give a grade according to if they like a student or not. They are not very objective. Today, you give a coffee to the staff physician, you go walk with them into the cafeteria, you chat about your life with him, they may give you above average for knowledge, which is completely non-relevant to it. But that's how sadly it works in medical school. So that's why you need to have good communication skills, good collaboration skills with other people, because you need staff physicians to write you good comments, and you also need 3 recommendation letters to get into residency. If you don't have any interaction with your teachers, you're never going to get any residency place. So the second thing in the hidden curriculum is that you have to establish contact with physicians in charge of residency program. That's also something very sad. You want to get into surgery, you have to contact the director of the surgical residency program. You have to say, hi, my name is blah, blah, blah. I'm interested in surgery. Is there any research opportunity? You don't do that for the research opportunity. You do that just to let the person know, look, I want to get in. And all the directors I've talked to in the past, they say, we just like to hire the students we know. If we don't even know you, why the hell are we supposed to hire you, even if you have the best marks? All we want to do is get people who can work with us later on in their future career. That's the number one thing they want. Third thing in the hidden curriculum is that you have to get good interactions with other colleagues. In medical school, you tend to be very, very friendly with all the other colleagues, although the atmosphere is one of competition between everyone. You have to know which specialties the other residents want to get in. Oh, so him and her, they all want to get into the same as me. They all want to get into general surgery. Okay, so let's see what they did. So that's why you need to have good interactions with other colleagues. You can know which opportunities they had, because someone who's isolated, who doesn't care about what the other people did, is not going to have a competitive application for residency. And if you don't get a good application for residency, you may land into rural regions afterwards. So that's the second step after med school applications, residency application. The other thing in the hidden curriculum is that you need to choose your rotations and your sites well. So students, medical students, have their own right to choose which hospital they want to rotate in. Mount Sinai merged this month. I chose it because my program allowed us to choose electives, to choose these programs by ourselves. So in this case, some hospitals have more friendly staff. Some hospitals have less friendly staff. It's just an atmosphere, you know. It's just like some countries are more friendly, some countries have more war. It's the same thing, but it's with hospitals. And it's very sad because some staffs who are in unfriendly hospitals may just write unfriendly comments to everyone because their mood is not good. And when you deposit this application to all medical schools across Canada for residency, they don't know which hospital is friendly or not. All they know is that the comment you get is below what other people got. So choosing your rotations and site well by having good interactions with other colleagues and by impressing your staff physicians, talking with them is key. And again, it requires good human interactions, communication skills, emotional intelligence, all that is tested with the Casper exam and with the interview and everything. One last part of the hidden curriculum of medical school is that grades don't really matter. It's pass or it's fail. But you have to do extracurricular projects and you have to get leadership initiative because CV is also very important for residency application. Almost all students in medical school will become a lead in the project, a lead in the research team, a lead in an advocacy group, Diabetes Canada, things like that, because you really want to have things above what other people's have. Okay, so now the last slide I have for the module 1 is about key competencies to survive medical school. I know you guys want to apply to medical school. It's very hard, I know, but study hard and also play hard. If you don't play hard, you won't have the motivation to study hard. So medical students have this. Oh, sorry, I think there's a microphone that's open right now. Yeah, thank you. Yeah, so you really have to play hard. So medical students have a tendency to drink a lot of alcohol after their exams. That's true. That's true. I was from a medical school that has this kind of atmosphere. So you really need to relax afterwards. You can't just study all day. And the first year of medical school, oh my God, like in 1 year, I think I crammed the same amount of knowledge as in the last 5 years. So yeah, that's the first thing. Second is you have to keep a positive attitude. You may have these situations of injustice in medical school where you feel, why the staff physician gave me a bad grade? Like, why? Sometimes you can just be purely unlucky. The staff physician may have just lost a patient yesterday at surgery at like 4 a.m. and he's just not in a good mood, and today's your final evaluation with him. He's not going to give you a good evaluation. So sometimes luck has to play into whether you get good comments or not from your teachers. But if you complain every time, it's not going to help you. So you have to keep a positive attitude because all the medical students had this kind of injustice in the past. To sue a doctor or to sue the program is not going to help you. A lot of students tried that, never helped them. It just delayed their medical school afterwards. So keep a positive attitude every day. Even though you may have bad interactions with nurses, with patients who are aggressive, passive, aggressive with you, hostile with you. The third thing, sadly, you have to know what staff physicians want. So yesterday I was in the emergency room. My teacher told me, look, take your time to do your consultations. Take 2 hours. You have to read around cases. I was like, okay, chill. I'll read around cases. It's going to take me 2 hours. But the day just before that, I was with the staff physician who told me you have to be fast. So everyone is just going to tell you something different. Medicine is very subjective. The teacher today tells you you have to be fast. The next day they tell you have to be slow. And you're like, why the hell are you telling me that? Well, yesterday they just taught me the opposite thing. So that's why you need to be always positive. Every day you just listen to a new teacher. You say, you know what? Just too bad. Yeah, sure. I'll be slow with you. The next day, oh, sure, I'll be fast with you. So that's how we do as medical students. You have to get personal initiative. As I said, you have to contact the program directors right after you get accepted to medical school to know where you want to go for residency, because that's the second fight you have after applying for medical school. You have to know your environment and your peers, as I said, because if you have a good hospital, if you have a good teacher, they're going to write you good letters, going to give you good comments. It's very sad because some teachers, they have a lot of enthusiasm to write you good letters, but their handwriting, their English is just so bad that even their best letter is not worth what an average letter from another teacher is. So you really have to know from your colleagues who's writing good letters. Their English written level is better. So it's very subjective. And you have to know that medicine is in constant evolution. So today, 37.8 degrees oral may be fever. The next day, it may not be fever because a new study said it's not fever anymore. And different studies always state different stuff. So you can see in med school that the Association of Urology of Canada and the Association of Urology of the United States may say completely different things. Screen or not screening for prostate cancer, and you're like, who am I listening to? So you have to know that medicine is not a perfect science. It's in constant evolution. Today, your teachers say, you have to screen for this patient. You have to read around the case. And you read around the case. The next day, another teacher says, why are you screening for this patient? And you know the teacher may be wrong, but keep a positive attitude and never go against this teacher. Never say you're so dumb and go read around the case yourself. Never say that, because your evaluation is controlled by every and each teacher. Okay, so that's the key competencies to survive medical school. In short, if you really want to apply to med school, you have to be dedicated to any of these specialties, and you have to get good social interaction. Someone who's mostly afraid of interacting with other people may not get an edge for residency application. And someone who just never wants to interact with other people, so medicine may not be the best choice for you. So in short, that's everything I have to say. So that's module 1. Thank you so much. Okay. Any questions? Still have 5 minutes before I give the Mandarin version of the class. You can all write the questions inside the chat if you want to. So what are some reasons to pursue med school? That's a very interesting question. So that's a common interview questions. And every year when we grade our students on these questions, all we want to see is, are you passionate about medicine? Because people all know medicine. It's one of the most prestigious jobs in North America. It makes a lot of money. They know that. And the GPA you need is so high that why not applying to medicine? But that's not the good reasons. So they may ask you a trick question at that time. They may ask you, have you had other options in mind? So other than medical application, have you applied to anything else? Someone who says, yes, I've also applied to law because it's also prestigious. I've applied to business because I also want to do business. These people just exploded their interview. They're going to get a red flag because these people are not for medical school. So be very careful when you answer these questions. Where else have you applied? Try to not say anything about things not relevant to medicine. That's one. Second, try not to focus too much on research, saying, oh, you know what? I've also applied for a research position because that's the purpose why I want to get into medicine. I want to do research. That's not how it works. If you want to do research, then go into a research master, then research PhD. Don't go into medicine. Medicine, it's patients' interaction first. All the research with you, right now I have a lot of students doing research with me So the research we do in medicine is rarely fundamental. We never go into labs to do it. Doctors do what we call clinical research. So they go see patients, they have surveys for patients, they look into patients' charts, they use Excel documents to calculate data about it. So it's almost never like you use and you use a cup and you put different kind of mixtures inside. We never do that in medicine. Okay. So what undergrad did you do before med school? So I am actually from Quebec. So some people today may also be from Quebec. And in Quebec, there's this thing. So we don't have an undergraduate before we go to med school. Like half the people in Quebec go from CEGEP, which is like grade 12, grade 13 in med school, directly to med school. So from CEGEP, after grade 13, they jump directly to med school. So that's what happened to me in the past. So when and how did you decide to choose family medicine? I would say it's mostly at the last year. So I was really fan about radiology and family medicine. I just didn't want to do something which would put my focus into just one organ. I just can't imagine myself like learning all that stuff and just forgetting everything afterwards. So on the last year, I chose family medicine because I'm also very fond of doing things with entrepreneurs. That's also my second passion. And I think family medicine is the best fit, where you can see patients of all age groups, you interact with patients, and you can also open your own clinics afterwards. Would you be open to email if we had additional questions? So there's a WeChat group. There's actually 3 WeChat groups. You can all go into these WeChat groups and ask me questions. I always answer these questions within 3 days. So you're welcome to come. The schools look at GPA equally. Do they make a weighted GPA? Yes, exactly. They make a weighted GPA. So some programs, undergraduate programs, are more competitive to get in. The average is higher, and that's making your weight GPA higher. So they make a new calculation according to the competitiveness of your undergraduate level. I've heard that undergraduate doesn't matter, but as you said, doing business might jeopardize your change for med school. So if you did business undergraduate, was that a bad idea? So undergraduate doesn't matter. You really have to explain why you wanted to change from business to med school. You really have to explain. That's the harder part. If you're able to explain, look, I was in business for my undergraduate degree because I wanted to help people, but the problem is it looks like everyone is self-interested, and then no one was caring for other people's interests. That's why I wanted to go into medicine. So you really have to find a good explanation why you want to get into med school from business. That's the hard part. But you're totally right to say that undergraduate doesn't really matter. Yes, you can take any undergraduate discipline before applying for med school. I have some colleagues, they were musicians. They played 10 years of violin. They were in musical school before, and then now today they're nuclear medicine doctors. So, and I have workers, I have like engineers, I have lawyers. You can go to med school from any undergraduate degree, but you really have to explain why such a big change. Does undergraduate student need to do the research work in order to apply for medical school? So research is not a must, but since medical school is so competitive in 2022, I would recommend everyone to do research at this point, because it's almost everyone else is doing research. If you don't do research, your application is going to be less competitive. Maybe Northern Ontario School of Medicine, these kind of less competitive schools may not need research, you can still get in, but U of T, absolutely you need research. Even people with 4 or 5 research projects may not get in. So I heard that research experience is very important when it comes to medical applications. So should we pay more attention to volunteer hours and patient hours and undergraduate or research experience? All of these are very important, especially for U of T or these programs where you need to be well-rounded because it's so competitive. Try to do everything. So on the CV, I'm currently coaching some students for their CV applications, giving them research and all kind of activities. So basically on the CV, you need to have research activities, volunteer activities, job experiences where you're paid, teaching experiences, if possible, have publications with the research. You need to have awards if you can, scholarships. You need to put your education, your membership with different kind of associations like Diabetes Canada. Maybe it can help prove that you're interested in medicine. So all of these structures. Do you think applying to med school in America as a Canadian medical student would boost our chance of getting in as they have relatively more med schools than Canada? That's not true. Because from the moment you apply as a Canadian citizen to American medical schools, you're going to become an international applicant. And as an international applicant, your chances of getting into med school is always like 1% instead of 5-6%. Okay. So now it's 8 o'clock. So thank you so much for attending today's class. We're going to start module 2 next week about shortcuts and all the different tips for your applications. So next week, same time as module 2. And for people already registered for these classes, I'll see you next week. And you're all welcome to join next week after registration. So thank you so much again.